Okay, we'll work when it's 20 past now, so we'll make a start. So thank you everyone for joining. I will go through a list of attendees as I've got them in just a moment. So this is the public board meeting of NHS Devon CCG on the 30th of April 2020. It's a meeting held in public. Unfortunately, because of current lockdown around coronavirus and technological limitations, it is not a board meeting that is going out live for our public to be able to witness, but it is going to be made available unedited for the general public to be able to view. And if any questions are generated as a result of that, please do get in contact. Please do email the CCG and we will endeavour to respond to those. We have an agenda as set out. Again, apologies, Nikki. We've got Virginia Pearson and Ruth Hurrell. Is that right?
It is, and Tracy Polak is going to be joining, hopefully, for Virginia.
Right, thank you very much. Sorry, bear with me. Okay, so welcome everyone. Before we start, I know that Simon is going to do a bit of scene setting, and I will actually invite Simon just to say something before we start as well, because I know he'll want to talk about his CCG team and the work that they've been undertaking. But I just thought I'd say something at the beginning. I don't know about you, but I wake up every morning wondering, entering this new normal, and just realizing this is a reality. This is what we are faced with, and it's something that none of us would have ever sort of imagined or thought, that we would be taking our roles as leaders within the NHS in Devon, of trying to guide our NHS and our NHS colleagues through this. It has become a new normal. It's a new normal for our staff, with home working, with working in a more versatile way, in working in different environments, doing different roles than they thought they were doing. It's a new normal for the public, and I think the public in Devon have been exceptional in the way that they have embraced social distancing, and I think the message that we continue to them is to keep going with that, because it does seem to be working. We are seeing the benefits from that in the ability for our health system to cope with the COVID cases that we're experiencing here in Devon. And for some, I think it feels like a struggle because there's a lack of control. It's a new condition. It's one that we are still learning about. It's one that has its own rules. And in an environment where often we operated within a degree of certainty and within a degree of control, it feels like that's been taken away from us a little in the situation we find ourselves. And that's tough for many of us to cope with. But I think the people I want to genuinely thank are the frontline staff, who some of whom are with the CCG, but many of whom are with our provider organisations. They're having to work in very different ways. They're having to interact with their patients clad in all levels of PPE. They're having to spend days behind masks that and aprons and gowns that are hot and limiting, and impair their ability to communicate as they would like to. They're putting themselves at personal risk, and quite often in different situations. And they have adapted so rapidly to different ways of engaging with their patient population in primary care, through electronic consultation, through video consulting, through managing a lot of people who they would normally see face to face, doing it remotely. We've seen over 85% of contacts within primary care happening that away from face to face, whereas it used to be 90% were face to face. And we've seen our secondary care colleagues doing outpatients in a very different way. We've seen orthopaedic surgeons learning how to be medical senior house officers in order to support their A&E colleagues and their medical colleagues. So many people have gone above and beyond and have adopted new ways and have taken those risks. And so when people stand outside at 6 o'clock, at 8 o'clock this evening and clap, It's those people they're clapping for, and let's not underestimate what they have done and what they continue to do for our population. Simon, I'm going to invite you because I know you'll want to say something about our CCG staff.
Yes, thanks, Paul. So firstly, I'd echo exactly what you've said, and I must admit, every Thursday when I open the windows and clap myself and listen to people around my area clapping, it's with immense pride around my role with the NHS, but also the role that all the CCG staff are playing in supporting those in the front line to be able to do what they can and are having to do. I just wanted to say again how proud I am to lead an organisation that's been so flexible in the way it's approached it. All of the staff, whether they're working on business as usual or have been redeployed or are meeting the challenges of the incident control centre, for example, have been very flexible, very supportive, and have really stepped up to the plate. Very, very grateful to my executive colleagues for the way they have dealt with the challenge. So as you know, we have set up a rota where we are working 7 days a week now, 8 till 8, to cover everything that's coming in, and everybody has done that flexibly, no complaints. And also to you, Paul, for the flexibility you've shown in being able to provide some clinical leadership to me in terms of dealing with clinical leaders across the system, but also with primary care. And just lastly, to my non-exec and clinical colleagues on the governing body, you're reaching out by email or by phone to both myself and to the exec team. You probably won't understand how uplifting that is just from time to time to get a little email that says we're really appreciative of what you're doing, and I listened to the staff webinar, for example, and you've done a really good job. It does keep you going, so they are very much appreciated. So that's all I wanted to say. Thanks, Paul.
Thank you very much, Simon. And our job this morning as a governing body is just to make sure that we gain assurance that our organisation is doing everything it can in the right way, both for the COVID-related issues that we have to face, but also all of those things that continue to be an issue for our public in their health and well-being. So thank you all as members of the governing body for taking that role and taking that role seriously. As we go through our agenda, first of all, let's start with the register of interests. That is on page, where are we? We are on page 5 of 72 onwards. So can I ask people to highlight any additions or changes that they feel that needs to be documented ahead of this meeting?
Paul, Nick Kennedy. As before, I've introduced the CCG to a PPE provider who may be able to source PPE from abroad that is partly owned by my cousin, although I've got no interest in the company at all.
Okay, thanks very much, Nick. So Nicky will make sure that that's noted. Anyone else?
Chair, if I could just raise that I have a position of therapy manager now with North Devon.
Thank you very much, Gaynor. Again, noted. And does anyone have any particular conflicts of interest that they need to declare based on the agenda that we have in front of us? No. Okay. Thank you very much. So the next item is the minutes, and the minutes are from February. We didn't have a public governing body meeting in March, and for those members of the public watching this, the reason for that was that that was right in the thick of the onset of the COVID pandemic, and it was our decision that we needed to allow our teams as much time and space to respond to that in a rapid and appropriate way, rather than preparing for a public meeting. But our determination was that that wouldn't be an ongoing position, and hence we have this public meeting now. So if we go through the meeting minutes from February, if we take it page out of 72, so we've got page 11 and 12. This is for accuracy. 13 and 14, 15, 16, 17, 18 and 19. So I see nothing in the chat and nothing from nothing's been raised verbally, so we will take those as an accurate representation of the meeting. We have got 4 actions on the action log. They are all for closure. Nikki, I don't think there's anything that needs to be added on those first 2. And Ginny, on the 3rd, anything to be added, or are we simply closing that?
No, it was raised at the last governing body. We needed clarification on a clause around indemnity for staff and how that related to GPs now that we had delegated primary care commissioning. And that's being clarified and agreed and changed in the constitution.
Fine. Thank you very much, Ginny. And then Nikki, the last one was yours as well, which was adding to the forward planner. And as they're all for closure, we'll assume that has been done. Thank you very much. So item 4, Ginny, that's over to you now then to talk us through the paper on our governance arrangements.
Okay, so this paper is setting out the arrangements that we've put in place around our governance arrangements during the COVID incident. As you'll be aware, we had a discussion at our last governing body around some changes to our arrangements in a verbal format to make sure that we had what we needed initially. As we've gone into a kind of a longer term arrangement, we've reviewed those, and the recommendations are here in this paper. So the first section of this relates to committees, very much as we discussed at the last meeting, that we would stand down our regular routine assurance committees. However, we would keep that under continuous review, and where we need to have those committees, those will take place. So we have had a primary care commissioning committee this month. We have an audit committee planned for next week. And we are reviewing the need for a quality committee in the fairly near future. So it's really important to state that although we are not kind of holding those routine meetings, and those meetings that we are having, we're holding virtually, the structure and processes are very much there whenever we need them, and we're reviewing that on an ongoing basis. The second part of the paper relates to decision making within the organisation, and very much the same message, so that we haven't changed any of our decision making structures or accountabilities. So where things would normally be going to an assurance committee for a decision, which is relatively fewer items, as they're sort of in their role as assurance committees, they don't make an awful lot of decisions. But where that's happening and those committees aren't being held, those decisions would come to the governing body for that decision to be made. We have a process in place, as we do with any major incident, for logging all decisions. So that's either through having logists and note takers at our meetings, but also each of our execs are holding a logbook in which they log any decisions that are made outside of those formal meetings. Has to be said, most of those almost all of those decisions relate to operational tactical decisions and things that are within the scope of the execs that are making those decisions. If, however, there aren't any decisions that are made that need to be made within very short timescales, and we can't do them within that the normal processes, we'll bring those to governing body for review. The paper also outlines the role of the NEDs during the incident, and highlighting very much, as Simon mentioned earlier, the buddying up system that we've got, so that the NEDs are in regular contact with the execs and making sure that they're very closely linked into what's being done. And we've also outlined in this paper an overview of our risk management arrangements. We're developing a risk register specifically for COVID risks, and we are also doing a review of our normal corporate risk register to identify those risks which are still need to be actively managed, those which are being managed as part of the COVID risk register, and those which are we're calling it suspended. So they are things that are not immediately relevant during the current time, but will become relevant again once we go back into business as usual. So we're making sure that we're really clear what needs to be managed and what doesn't, so that we're not creating any extra bureaucracy, but we're looking at the things that we need to. I've had notification from our internal audit providers this morning that NHSEI are making recommendations around a review of governance arrangements for COVID. and that review will be starting fairly shortly. And I'm fairly confident that the processes and structures that we've outlined in this paper will make sure that we come out of that audit having ticked all the right boxes. Very happy to take any questions.
Thank you very much, Ginny. There's a couple of things that have come up in the questions. One of them was an ask from our clinical locality representatives to see whether they can join the non-executives at their monthly meeting. Simon, I'll ask if you can liaise with Nick Ball to see whether you can link in and have a regular point of contact between clinical and non-clinical non-executive members of the governing body. I think whatever contact we manage to continue will be very helpful. There are informal touch points, so the clinical representatives meet with myself, meet with me once a week. And Simon and I meet with the non-executives once a month, sort of 2 weeks following each governing body meeting, sort of halfway between those governing body meetings. So there are those touch points to try and keep the whole of our governing body as briefed and informed as possible. So, John, you've raised something about the minutes. Let me come back to you on that one. I think if Nikki can confirm that those written answers, it was just a question about, there were questions raised by the public and we said we were going to answer them in writing. I'll ask Nikki just to confirm that we have, and if so, then we'll document that that's been the case. Thank you. Any questions for Ginny? So the ask from Ginny is for governing body, particularly for the non-executives, to be assured of the arrangements, the governance arrangements that we have in place. By silence, does that infer that our, particularly I'll look to our non-executive members, our non-executives are assured by the current process? Nick Ball will come in. I think you may be on mute, Nick.
Sorry about that. I just wanted to reiterate that the governance arrangements that underlie the decision making in the CCG remain unchanged. You know, we've changed the process of how we hold committees and the frequency, but the structure of our governance processes is still fundamentally unchanged. I think it's important that people understand that.
Then I guess just for clarification for Nick and Ginny, does that mean that the delegated authorities to our executives and to our accountable officer remain the same, that they haven't changed?
That's true. And it's always been the case that the levels of delegated authority that are open to use by the Chief Exec and Finance Director in combination are fairly massive. So there is a high degree of flexibility, quite rightly, for our execs to get on and do stuff.
Thank you. Graham, you wanted to talk about reputational risk.
Yes, thank you, Chair. First of all, can I just say how pleased I am with this report. It's great to see that we're having a decision log. I would prefer it to see that ratified at the next available governance meeting, rather than it being left to committees when we are back to some semblance of normality. Just in terms of the risks right at the end of the report, I just wonder whether we need to be adding a fourth risk, just around reputational risk in respect of COVID.
So in the draft COVID risk register that's coming to audit committee next week, we haven't got a specific risk around reputational risk, but we've picked up where reputational risk would be an impact of specific issues. So, for example, PPE, where we have a sort of key role in coordinating that. If we aren't able to supply what's needed, then that would have a knock-on reputational impact. So it's reputation is a kind of an impact rather than a risk in itself.
So are you then, Graham, comfortable with that leaving that not documented as a risk?
I'm certainly comfortable for now, and we can pick it up at next week's audit committee should we feel we need to.
Thanks. And can I just ask for clarification? I know Nick Ball wants to come in, but you were talking about the decision log, wanting sight of that at the next governance meeting.
If I could
so
clarify.
You wanted to see the actual log presented at our next governing body meeting. Is that your request?
A log of those decisions which are not capable of being done under normal procedure. So if I'm looking at section 2.1 of Ginny's report, it's about the 6th bullet point. It talks about decisions made outside of normal process need to be logged with the governance team and then either ratified at a governance meeting or picked up by a committee when back to normality. I'm saying that I would prefer things being ratified at the next governance meeting. I don't think we can wait till we're back to some form of normality.
Yeah, I think that's absolutely right, Graham. Yeah.
And I'm agreeing with Nick that, of course, there is substantial delegation and the decisions we're talking about are likely to be very few. And I'm suggesting they should be done at each governance meeting, whether that's a virtual committee or governing body in the absence of a committee.
Okay. So can I just clarify then, Ginny? Sorry, I was just going to ask you, when you use the phrase governance meeting, what do you have in mind as the meeting where that ratification takes place?
So it would either be at the relevant assurance committee, which, as I said, some of those committees are continuing to meet, or coming to governing body. The point I was just going to add in there is that as part of preparing for this meeting, I've checked in with the our head of governance, who's pulling together the decision logs as part of the instant review, to see whether we had any decisions that had been made outside of process or not in line with our scheme of reservation and delegation. And to date, we don't have any. So I'm more than happy to bring those on an ongoing basis to this meeting, but just to record that we haven't had any of those decisions as yet.
Thanks, Ginny. So I suppose at each governing body, any of those decisions that do occur that haven't been through a committee, then those are the ones that would need to come to governing body. Is that fair, Graham? You happy with that?
Very happy with that. Thank you. Thank you, Ginny.
All right. Nick Ball.
So just coming back to Graham's question about reputational risk. Should we be recording a reputational risk around the presentation we saw earlier this morning? If there is going to be a significant risk of a bad second and potentially bad third wave, that is likely to be returned as a reputational damage to the CCG, isn't it? Because people will say, oh, it's just about bad management.
Okay, so if I just put some context in for any public members who are watching this, we have done some internal work looking at what is the likely scenarios going forward, depending on any of the government policy decisions around social isolation. And there is some suggestion that on lifting social isolation, there may be a further increase in COVID cases. And so, Nick, I guess your point is that are we in a position now where it is perceived by the public that the NHS have said that we are through the peak and now in a period of recovery? And I wonder whether there's a question for Andrew about what sort of the messaging priorities that you would want to be giving to our public right now around where we are likely to find ourselves at the moment.
Thank you, Chair. I think it's important. I mean, Nick's point's a really good one, but I think in all of the public messaging, I think we've been really careful to set out that clearly at the moment the numbers of cases in Devon are low and are falling. However, we are planning. For example, as you know, we have a new NHS Nightingale hospital set for Exeter. We are still planning for a possible increase in cases. And I think we've been really careful to make sure to the public that that's the case. So we've been reinforcing that people should stay at home, make sure they protect the NHS and save lives. And actually, so I think, Nick, there is a balance there that we have made sure that the public are aware that whilst we're managing things well at the moment, we're still preparing for possible increase in cases.
So I wonder whether the risk that we are talking about is that we are currently and have been over the last few weeks making decisions in the moment based on the information that we have available at that particular point in time. And only with retrospect, learning and experience will we know whether those turned out to be the most appropriate things. But we've got to be really clear that we try and ensure that we are not judged with a retrospectoscope in a way that is reputationally potentially damaging to not just us, but the wider NHS. But that we are clear in our messaging that we are endeavouring to make the best decisions based on the information that we have available to us at any one particular point in time.
And could I add, Chair, that I think it might be worth reinforcing that obviously as Devon CCG, we're obviously following really closely the national guidelines and national guidance that we get in as a system. I think that's really important. We're guided by obviously the Department of Health and Social Care, obviously government, and obviously our regulators in the region. So I think we're pretty confident that we're really following all the best evidence and the information we've got at present.
Okay. Is that okay, Nick?
Yeah, that's great. Thank you.
Okay. Thanks very much. So then, while those questions came in, there were a number of our non-executives who have put in the chat that they feel assured by the arrangements that are in place, and I think the clarification from Graham around some of those the process around some of those decisions is helpful in clarifying that. So Ginny, I think we take that as governing body being assured. Thank you very much. So Simon is now the opportunity to do some scene setting for us to give us a bit of context as to where we are at the moment. Thank you.
Yes, thank you, Paul. So just a quick update. So in Devon, the number of positive COVID cases that we've had as of yesterday midday was 1,123. Sadly, we've had 140 deaths associated with COVID, and those are statistics that are from the national available statistics, and we have 10 people currently in critical care, so quite a low number compared with other regions in the country. So the southwest remains the lowest, has the lowest incidence of COVID in the country, and Devon, Somerset and Cornwall are the lowest in the southwest region. So at the moment, social distancing is definitely having an effect in the southwest and in Devon in particular. But we do know from the internal modelling that we've done to just help us inform our planning that as social distancing is relaxed, whenever that takes place and whatever decisions the government make, obviously we will comply with those. We do know there is a risk of larger peaks down the road for us as those are relaxed. So we'll continue to modify our modelling based on what comes out nationally, because we will follow, as Andrew said earlier, continue to follow the national guidance and national support and intelligence that comes out. So we'll make sure we do that. So I also wanted to say, Paul, so I referenced earlier on in the meeting the support that the executive team and the CCG as a whole has put forward, and it's been well received by the system. Sonia will go into a bit more detail about how we've set ourselves up, what we've been doing, and then each of the execs that lead on particular items will go through in detail. But I just wanted to give some reflections on what I think are some of the positive changes we've seen. What are some of the things that we believe we need to go further with in terms of improvement, and just some personal reflections on why I think we've been able to change so rapidly. So when I say personal reflections, they're also built upon conversations with my both the executive team and with my CEO colleagues across the system. What we've tried to do is frame it through what are the long-term plan aspirations that we had before all of this started. We'd set out a long-term plan. It wasn't signed off formally because we've reported previously to you there were still some financial and performance issues that we had to work through as a system and with region. But one of our aspirations was around digital and enabling digital technology, and to reduce our face-to-face appointments or activity. So we've definitely seen a rapid adoption of technology and significant improvements in terms of outpatients, primary care e-consult, and mental health activity being undertaken non-face-to-face, so things like iApt. We've seen a great deal of flexibility in terms of our workforce and people working across both professional boundaries and to the top of their license, which is something that we've talked about a lot in Devon. We've had a workforce strategy for a while, and we've been striving to try and break some of those professional boundaries down. Pleased to say that we've seen that take place over the last 4 to 6 weeks. We felt we were always good at mobilising our voluntary and third sector. Again, that's been accelerated even further during this period. So, for example, being able to accommodate rough sleepers and the work that's being done in Plymouth in terms of supporting the vulnerable, that's happened across the county. But those are just a couple of examples. I think the blurring of the lines between in and out of hours of primary care, so DDoC, the 111 and out of hours provider, is definitely working much closer with our in-hours primary care to try to come up with some solutions that work for primary care across the whole 24 hours. And we've been able to see 7-day working adopted pretty much across our entire sector, including our commissioning staff are now working a 7-day week on a rota, and that's allowed us to be able to be much more nimble in terms of support that we can provide. I think some further opportunities, we're obviously seeing growing waiting lists, and we need to be able to try to manage those effectively, and I'll come on to that in a second. We've seen a bit of put a spotlight, I think, on the care market, so particularly care homes, not only about the sustainability of some of our smaller homes and the infection control mechanisms that they haven't really been able to adopt as well as we thought they might be able to, but also things like specialisms and the lack of EMI beds, for example. So I think there's a bit of work to do there. And some of the behaviours of the population has been both positive and negative in this. So we have seen our ED attendances reduce rapidly and significantly. Some of that's been about minor injuries, minor illness, not attending ED, which is absolutely right and proper, but some has been about not seeking support and advice when they really should do. So there's a careful balance to be had there. We've also been able to establish new safe thresholds of care and access to services, which we've been seeking to do for a long time. And we talk about rebalancing the risk threshold across all sectors, and I think that's been one of the things that has been really good for us. And the last thing I think in terms of that has been our ability to really reduce our bed occupancy. So colleagues will remember that both Sarah, Sonia and Joe have reported before that we've had bed occupancy at over 100% at times through winter, and that there was a new target that had come out to reduce that to 92%. I think it was. We've managed to get our bed occupancy at times down to below 50% across the county. Which is been enabled by our very close working and focus with our local authority colleagues on things like our medically fit for discharge list, and those are things that we can't lose as we come out of this pandemic. I think just some reflections on how and why I think we've been able to adopt that rapid change. So obviously we had a necessity, a clear and compelling goal, which united us all, that we had to do this to face this pandemic. I think people have said the organisational autonomy within an agreed set of parameters, but not needing to keep coming back and checking through multiple governance layers. Now, governance is important, and we talked about that in our previous paper, but the ability within a set of safe parameters to be able to get on and implement things at a local level has been has been really good for us. And I think also what I've heard is that a controlling mind, but a collective collegiate mind by the chief execs and the chief officers, and a regular check-in. So I'm meeting with the DASs and the chief execs of our NHS colleagues, including DDoC, on a daily basis for half an hour. That ability to rapidly turn around wicked issues and have a controlling mind and a consistent approach, I think has been a real benefit to the system. So if I move on just to the fact there was a letter sent out yesterday by Simon Stevens and Amanda Pritchard, so the leadership team of NHSE and I, talking about phase 2 of COVID and how we can start to restore some of our services. I won't go into detail in the letter, and I will provide that for you later. But we've got John Finn and a team of leaders or executives and deputies across the whole of our health and care system are working on how do we start to stand up services, in what order, and what are those things that we need to do. We'll make sure we get that process. John Finn's bringing a paper to our executives tomorrow morning, and we'll make sure we set that out for you. That was all I was going to say, Paul, and Sonia may wish to say something else about how the incident is being run from a leadership perspective, and then I know colleagues are going to talk a bit about the detail of each of the cells.
Okay, so anything from you, Sonia, and then we do have a question around care homes that doesn't neatly fit into another agenda item, so we'll pick that up after you, Sonia, before going through the other elements.
Okay, thank you, Chair. So just a bit about our incident response and how we're set up, as Simon had alluded to. So we have been asked nationally to set up our incident response in line with the expectations as set out by the government. So we run a 7-day incident response, extended hours, 8 till 8, but also on-call activity as part of that. It is supported by a set of cells, which we've endeavoured to align with region as well. So 8 cells, which are each led by a CCG lead, but also supported with an executive. And we are constantly evolving and adapting those depending on where the high risk areas are in the system. Those 8 cells, while they lead our incident response and deal with certainly some of the operational, clinical and other risks that we are dealing with and supporting our providers and partners, are supported by wider programs of work. So particular areas of focus where our experts are developing, for example, children's and maternity and others as well. We also have very clearly mapped out the details of how we communicate and engage with all our partners across the system to support our population, but also how we deal and escalate issues into region and nationally, as well as resolve and take decisions in line with, as we just discussed, our governance in the system. I think it's probably fair to say that a lot of the issues that we've been dealing with since the start of the response, certainly since our last governing body meeting, have been around preparing and dealing with the peak that we've seen, the growing prevalence of COVID in our population. So as we heard, supporting our hospitals to be able to reduce their bed occupancy and create that capacity. Very much focused on PPE, supporting and working in line with national guidance to make sure that we are adequately equipped to support all our patients, in particular those with COVID, and our staff with the right PPE. And Philip will cover a lot of that as well, and particularly in sufficiency, but very much in mutual aid processes as well. We've been focusing on primary care, and Joanna will give an update on that. Very much on testing in support of the pathology network around staff testing predominantly, but now wider as well. So the systems and processes that we have in place are constantly evolving. They're very robust. They're certainly in line with national expectations, and we will continue to give updates as necessary. I think I'll pause there. Happy to take any questions, but obviously my colleagues with particular areas of expertise will give an update on those as well.
Okay, thank you very much, Sonia. So we've got a couple of general questions. First of all, Graham, you wanted to talk about the context setting, and Glynis, I haven't forgotten about the care home. We will bring that in.
Thank you, Chair. My question is for Simon. and it picks up on a discussion that John Dowell and I have been having over recent days. Simon, you talked very clearly about all the positive changes that have come out of this, and we've used phrases before about never waste a crisis. Many of the things that are positive and that have happened quickly are things that we've been trying to do for some long time, very often driven by the financial imperative, the need to get back into financial balance. It's now succeeded because of the clinical imperative and the fantastic clinical leadership that has been shown in this period. How do you think we can capture that clinical leadership going forwards and not return to the old language of needing a financial recovery plan? We actually need a corporate recovery plan, which picks up both the clinical side of things and the financial coming together as one.
Yeah, Graham, I think you're absolutely right, and it is something as a chief exec group we have reflected on, and it's certainly been part of our language that. So obviously we need to do the financial work that sits alongside it to see what impact the changes that we've made would have on our financial model, but that's not been the reason for making those changes, as you've said. So I think it's been maybe not an eye-opener to us, but it's been a really pertinent reminder that if we focus on doing the right things for our population and we listen to our clinical leadership appropriately, then we will get the answers that we desire out of the other end, and that should be our driver, not the finances. That's been a very clear message that we have reflected on as a chief exec group, and so I must say that chief exec group has been very open to listening to different ideas. So it's obviously our provider colleagues as well as our DASs. So I think a very good relationship between the commissioner and the provider in that space.
Thank you, Simon. Simon Kerr has asked for you to comment on Simon Stevens' letter and its relevance to Devon. In fairness to you, we've had the letter for 24 hours and the team are still working on it. Any early views on that you have, Simon, or are we simply awaiting a little bit more of an in-depth review of the asks within that letter?
Yeah, it would be nice to complete some of that work, and again, that won't be complete by tomorrow morning. But what I'd say, Simon, you're absolutely right. Our initial reaction to that is it might be it'd be different in the southwest because we've had such a low incidence that we will need to be, as some of our internal modelling suggests, we'll need to be very mindful of the fact that we haven't had our peak yet. So as they have in London, they had a very high peak. We've not seen that. So we need to be really mindful about as social distancing is lifted whenever the government decides to do that and in which order they decide to do it. We'll need to be able to respond to that appropriately based on the planning and modelling that we've seen both locally and nationally. So I think it could be different in the southwest. You're right.
And then Glynis, you wanted to ask about care homes. This was particularly around supporting them around infection control. And I know it's been an issue. I've personally been involved in a couple of care homes that have needed quite a lot of support when they've seen outbreaks of COVID within their care home and the importance of getting that infection control and that PPE supply right. Glynis, do you want to articulate it? And then I think Philip will be able to come in with an answer.
Yes, sure. I mean, when Simon gave his update, he said that, there was lots of really good stuff that we absolutely have to learn from, but he also said that the issues around infection control in care homes had been surprising to some extent. So I just wondered what we were doing about that and what we were putting in place, particularly if we are likely to see further cases.
Okay, Philip, you've been doing a lot of work with care homes. Do you want to come in on this?
Yes, so I think 3 points. The first one is about the context that you've just set, Glynis. I mean, it is true to say that some care homes are very good in terms of their infection control. However, the scale of what we are seeing is unprecedented, and that does place stress upon them. Other care homes, particularly where they are not supported by an infrastructure of being larger or a larger chain, are more vulnerable. So I think the way that I would phrase our response to that has been twofold. I think where there has been an outbreak, there is a system response, and that system response is working with Public Health England and the local teams around that. And then there is a very swift conversation about what is the best way to support with not just the outbreak, but also particularly around infection control. So that may well be, and has been, colleagues from acute secondary care who've actually gone in, or community providers who have gone into care homes to provide the necessary support. We are part of that, and there have been examples where our own teams of nurses and doctors and indeed our chair have been into care homes themselves to assist where absolutely necessary. So I think we have had some good response about that. I think the other thing to say, though, is that care homes, I think, are obviously anxious. It is a novel and unknown set of circumstances for many of them. And what we've done with that is twofold. So we now have a weekly webinar in terms of providing information and support to care homes, which I chair, which happens on a Thursday. That is open to anybody. It is open access, and any member of the public can look at that. But it is focused around care homes, residential homes, domiciliary care and out of hospital care particularly. Last week we focused specifically on PPE, everything down from hearing from the Director of Infection Prevention and Control, Rob Porter, from the RD&E, which was incredibly helpful, and some very practical things around what care homes can do, things like donning and doffing PPE, cohorting, etc. I think it's fair to say that there are some specific challenges, for example, specialist care homes where there are people with dementia. Cohorting and normal infection control processes need to be adapted to the specific populations. And also to say that Sonia mentioned about the cell structure and our response to the crisis. We have our infection control team within our clinical cell, which I lead and links into the overall incident management process. Those are staffed 12 hours a day, 7 days a week, with a clinical input out of hours as well overnight. So there is a lot of support going on, working also with our colleagues from local authorities. So I think we can, I think, again, to echo Simon's point, I think the response we've had from our own teams has been exemplary in very difficult circumstances to help support care homes which are particularly at risk at the moment.
Thanks very much, Philip. Charlotte, just one question on prisons from you, and then we'll move on to looking at the different elements, starting with primary care.
Thank you, Chair. So my question is about, have we done any modelling around our Devon prisons, given that we have 3, which is obviously quite a lot for a county, plus, you know, with a number of them with people who have underlying health conditions, / somewhere like Dartmoor, where you've got high volume of people who are sort of older. So that was the kind of first point. And I suppose secondly about, I know the staff, it's private sector Care UK provision, but I suppose in terms of staff resilience and care and support, because ultimately they're still, you know, staff doing a very difficult job.
Okay, so Penny and Sarah, you said you can come in on that. So Penny first.
Yeah. Okay, yes, Charlotte, the health and justice part are modelling very carefully what's going on in the prisons. At the moment, the outbreak is very low, so it's all business as usual. I don't know, Sarah, whether you've had any further update, but the national modelling is being undertaken, but actually at the moment there's very few cases. I'll hand over to Sarah.
So absolutely, as Penny suggests, yesterday in the critical care cell, we looked at an escalation plan specifically for prisoners who would test positive, who needed access to hospital care. So we're both close to these issues, and it's being dealt with at a regional level.
Thank you.
Okay, thank you very much, both. Can I hand over to Judy and Joe then to take us through to 5.1? Let's with primary care.
Okay, so I'm just going to do a quick overview, and then Joe is going to cover more of the detail. We have had a primary care committee. We felt it was appropriate to do so because so much is going on in primary care just at the moment. Indeed, so much is going on everywhere else, but there were one or two things that we felt it important to report to the committee. I just want to start by saying that I have been both impressed and surprised by the amount of detail that people have had to go into in primary care and in the CCG, just in terms of delivering the day-to-day service. Virtually everything is changed. And I think as a member of the public, we sometimes don't understand how much every single process that people are doing every single day has been affected by this. There have been massive changes in the way that primary care has been delivered, and both staff and patients have reacted incredibly positively to that. People are, working to these new patterns of delivery of care. And I think, as Simon was saying, there's a lot of stuff, we should be aware of as we move forward about how there have been some positive changes in this. And also I'd like to just respect everybody in primary care and in the CCG about how people have engaged in discussion and negotiation about the way forward on this. There are some quite tricky issues being handled in primary care, and there has been a very positive dialogue, and those weekly webinars, I think, are absolutely key to that, although, of course, there is a mountain of work going on in the background. At the committee, we were assured about the way in which decisions are being made on primary care at the moment, so we had a briefing on the processes. We also considered and noted some changes in the way in which the current contract, aspects of current contracts, some details, for example, about how we're going to measure things like the QOF targets. So we noted those and noted they were within the decision-making framework. We also noted there are some discussions still going on, and they will continue to go on, but there are some complex issues about funding some of the hub work that is going on. And so we considered a basic approach that the CCG staff would take in discussing this with practices and the LMC on behalf of the practices, and looked to follow national policy. We looked to be flexible around, specific local issues, but also to recognise that there have been other changes made that are pertinent to the way in which we handle the subjects of funding these COVID-19 centres. So, I think certainly from the non-executive directors on that committee, a massive sense of respect for what everybody's doing in this situation. And now I'll hand over to Joe to give you more detail.
Thank you, Judy. That was a really helpful overview of some of the key issues and decisions we made at PCC. I think Nikki is just going to hopefully share just two very quick slides with you so that I can just talk through some of the key issues at the moment. We can other people see the slides or no? How are you getting on, Nikki?
Sorry, Joe, I have they're on my screen and I have shared my screen, so I'll just try and see if I can pull them up again.
Okay, thanks, Nikki. In the meantime, I'll just try and pull them up myself.
Can you see them now?
No.
No, I have shared my screen.
Okay, just bear with me for 2 seconds then. I'll just pop them up on my screen and I'll just talk through them.
Sorry about that, Jo.
That's right, no problem. Okay, so so as you've heard from Judy, significant amount of work has been going on in the primary care cell, which we established probably about 8 weeks ago now, when we first had our first outbreak in Devon. So a lot of progress has been made since then. A lot of changes have happened. So I won't talk through everything that's happened in the last 8 weeks, but I'm just going to really reflect on key achievements and progress in the last 4 weeks. So significant amount of work has been done by the team in relation to splitting out how we or splitting out the pathways for COVID and non-COVID patients in primary care, and also including within that how we deal with the shielded patients as well, and how those patients are cared for in the community. We've been able to identify sites, so COVID sites, whether they're either within primary care, within general practice sites, or within other sites within the community. We've been able to establish those across Devon in all 4 of the localities. Some of those are up and running at the moment as we speak, so some of the sites in East and West and also South as well are working at the moment. We haven't necessarily moved to using the COVID specific sites in all areas of Devon, and that's just really a reflection of the demand at the moment that we're seeing for that. So where practices and primary care networks can cope with using their own premises at the moment, they are continuing to do so, but we've also implemented an assurance process as well, just to make sure that we're all really confident around the infection control issues as well, and that patients are getting seen and treated in an effective time period. We've also agreed a home visiting service, and thank you to Devon Doctors for working with us on that. We have 8 vans that will be used across Devon, and they will be ready for next week should localities want to use them. Also in the last 4 weeks, we've put out palliative care guidance, and also guidance as well on supporting care homes for general practice, and that includes a LES that we've put out to general practice to support residents in care homes, but also in care hotels in Devon as well. As you heard from Judy, we're holding weekly webinars. We do that every Friday, and I've had some really good feedback that's really appreciated by primary care. We also hold weekly meetings with the LMC and the collaborative board chairs, and I think one of the things, as well as the huge progress we've made around digital, is also the progress we've made in terms of working with general practice, the LMC collaborative board chairs, but also how those collaborative boards are working amongst themselves as well has been fantastic. And it feels like we've moved into a new phase within the cell. So at the beginning, everything was very new. We were getting processes up and running, and we have moved into what might be considered a new norm. So there's lots of questions still coming up, new things coming up every day into the inbox, but some of the things we're dealing with on a regular basis, like PPE, patient staff testing, IT support, and things like making arrangements for bank holidays, etc. It does feel like we've moved into a new norm with some of that. And at that point, it's worth saying, I think how effectively the cell has worked. So Mandy Seymour, our Associate Director for Primary Care, is leading that cell, with Jenny Turner supporting the incident response, and Paul Baker leading the operational and business as usual elements that sit behind that as well. And just in terms of key issues, just moving forward, so just briefly, just focus on some of the things that we are still looking at the moment and developing. So anecdotally, and we heard it earlier on, primary care is getting a bit busier now. So it's really that balance between what primary care is currently doing to manage the balance between COVID and non-COVID, but also reflecting on Simon Stevens' letter from yesterday in terms of some of the activity that we're expecting to be stepped up as well. We're also looking at potentially whether our COVID sites are in the right place for the long term as well. So very much they were set up very quickly in response to what might be a really high peak. We haven't seen such a high peak as we might have thought, but of course none of us know what will happen in the future. So we are just looking at the longevity of those sites and at what point we might want to trigger moving completely to those hub arrangements in primary care. We're also to continue to work around how we coordinate better the care of those individuals on the shielded list as well with our community health and social care teams and also our local authority colleagues as well. And as Simon Stevens' letter mentioned, one of the things that will be stepping up in primary care is the enhanced health in care homes work. So we will be working with primary care to understand how we can do that in a manageable way. We also, as Judy outlined, we continue. So one of the big pieces of work for the team at the moment is around expenses for GP, so how we're just covering the costs of COVID. So that continues to be something that's taken up a significant amount of time for the team. And then, of course, we are thinking about how we stand up gradually in a balanced way some of the business as usual and also build on the accelerated progress we've made around digital and PCN development in particular. So I'm going to pause there, Paul. That's all I wanted to say.
Thank you very much, Jo. I'm just going to echo Judy's comment about the primary care team. I do want to congratulate you as well as the rest of the team that actually it's been a huge demand and it's been managing 137 or so separate organisations and all of the primary care networks and the collaborative board chairs and the LMC. All with different pressures and different agendas, trying to pull them all in the same direction. And I think the team has worked tirelessly to try and achieve that. So well done. Any questions for Jo? I think it's all looks quite quiet at the moment, Jo. I think your briefing must have been comprehensive enough for people to be happy. Now, David has a question. David Greenwell, do you want to come in?
So I think this is. Sorry, can you hear me? I think this is a specific question to South. Potentially, I just wanted to know whether the Primary Care Committee regards work in the Hot Hub as part of core general practice, which every practice should be getting involved with and doing their fair share, or whether it's something that either existing funding should be reallocated to, or whether new funding is required for it. And I'm just concerned that there's a discussion over how this is going to be funded is actually delaying the implementation of what is essentially something that should protect the safety of general practitioners.
Yeah, so I'm happy to answer that, David. So we did have that discussion at the Primary Care Committee. So Judy alluded to a discussion about reimbursement and funding. So we did do that, and we made a decision, which we then communicated on the webinar and in the bulletin to general practice last week. So I don't think, for me, it's not a question of core and non-core. I think, as you said, David, it is about the flexibilities that have been given nationally around releasing capacity for things like QOF and LES work, and also the flexibilities that we've given locally as well beyond that around repurposing extended access. So the message that we've given out to general practice is that those flexibilities have been afforded nationally and locally and should be used to support COVID work, as is the intention, but that we have around if practices get to the point, and that could happen as we're standing up some of that routine work again, if they get to the point where that goes above and beyond the capacity that they have got through those funding, then we would want to have that conversation with them, and we'll review what those additional payments need to look like. It's also worth just mentioning, so at a national level, and it is, and I will say for myself, Paul, and the team, it is difficult working without national guidance on some of these things, and we are putting local guidance out there for our practices to enable them to carry on, and sometimes that gets followed up by national guidance at a later point. But certainly we've been told by the national team they are looking at a funding package, particularly for when general practice gets more to business as usual, although we know that might be delivered in a different way, and general practice gets busier at the same time as COVID still being an issue for us. So we wait to hear what they say on that. I also just want to, sorry, Paul, just to acknowledge Sheila and Judy mentioned the, I think, incredible support that we've had from IT. Which I think for Jim Goodwin and his team and from Dell has been fantastic, whether that's either getting laptops and other equipment out to general practice or supporting us to the webinars. So yeah, I'd really like to acknowledge that as well.
Okay. David, I was just going to go back to your point, because I think what it demonstrates and what the team have had to manage is that I think it is very easy to say that looking after patients within the community, whatever the conditions, when they need primary care help, is a core responsibility of primary care. But that has to be taken into the context of when you are operating within our current environment and you have to segregate different patient groups because of risk, and you have to use PPE in order to protect yourself and protect the patients, that core responsibility involves an increased amount of work in order to cover. And I think that's where the conversation is, where we have to try and bear both of those in mind, so that patients get the care they need, because it is the responsibility of general practice to provide it, but we make sure that they are operating in an environment that allows them to do so. There has been there's been a couple of points. One is around how do we make sure that we take the good learning going forward. And so, Joe, it'd be useful to know what are going to be the plans of trying to embed some of these new ways of working that we see are beneficial for primary care.
Yeah, thank you, Paul. So it will be, so I suppose two things to say. I was just actually responding in the chat to Simon. So I think it would be fantastic, particularly our governing body GPs are really well placed to collect some of that good practice that's happening, as well as our collaborative board chairs as well. So I think if we can collate some of that good practice, my plan, and we have thought about how we might do that for some of the work that's going on in care homes at the moment, particularly I know in the coastal locality. My plan would be that Paul and I can share some of those insights on the webinar, and even get some of the GPs to come and join us on those guest slots on the webinar to share that, and also put some of that information out on the daily bulletin. But in terms of the more longer term, as you'd imagine, the team are already starting to think and link in with the recovery cell around how we want to embed some of these new ways of working in the longer term as well.
Thank you very much, Joe. I think there is a comment from Sheila which says that the Friday webinars have been well received. I think that reflects it's interesting how we've become locked down, but probably are better at communicating with our system colleagues than we were before lockdown. So that's another bit of learning, I think. It's not just our relationship with primary care, it's the same with care homes and with our acute providers and local authorities, that there's a learning that there is so much that's possible remotely that we need to hang on to make sure that engagement's as good as possible. So thank you, Sheila. And I think that's another learning point we should be taking forward. Okay, well, thank you very much, Joe and Judy. Let's move on. Philip, then talking through PPE, and that takes us to page 29 of our packs.
Yes, thank you, Chair. I'm not sure if it's possible to put the slides up on the screen. I think, Paul, you might be trying to do that. You're also on mute, Paul.
Philip, are they the same slides that are in the pack?
Yes, they are.
So if everyone should have access to the pack. So your first slide is page 29. So if you talk us through the slides, and then we can then refer to them ourselves, is probably easier, because it looks like the technology isn't allowing sharing at the moment.
Great, thank you very much, Paul. So I think the first thing to say is, just by way of context, I think it's hard to underestimate the importance that PPE has played in terms of the COVID-19 epidemic and pandemic. And it's been absolutely key in enabling us as a whole system to respond to COVID. That's not just about reducing infection and preventing its spread, but also in terms of keeping staff and patients safe. And also there's a significant degree of giving confidence to staff across the whole system of health and social care, and indeed to the public around the issues that this raises. For us, it's been a particular priority. So in the early days of the pandemic, PPE was part of our clinical cell, but very quickly we decided it was important to set up a particular PPE cell to respond under the leadership of some of our senior staff. And indeed, this subject has executive sponsorship from Simon in his accountable officer role, and John Dow on the opposite team to Simon, which has been incredibly helpful, where we've had to, on occasions, escalate issues with some rapidity and to respond swiftly. So turning to the slides, the separate cell that we have is staffed 12 hours a day, 7 days a week. I think it's worth saying that again, and I don't want to over stress this, but I think it's really important that the staff within our PPE cell have responded and stepped up in a way which is incredibly gratifying, sometimes undertaking work that is out of the normal way of dealing with PPE and supply, and having to be very creative to solve problems. So we continue developing and expanding the PPE team, which has been incredibly helpful because there's been such an increased workload, demand and resilience requirements. So we have 4 work streams, and I think it's probably useful to state, although it's within the slides, that our role in this is multifactorial. We have a system coordination role around monitoring, about ensuring that where possible mutual aid is undertaken, where we are looking at coordinating donations and alternative ways of sourcing PPE where there have been significant local and indeed national shortages. And our aim is to try and respond in as timely fashion as possible, particularly where, for example, local authorities or acute hospitals have had specific difficulties. We have attempted to follow all the national guidance, and I think we've succeeded broadly in that. It is worth saying that the national guidance has changed on a number of occasions, and we've had to respond very quickly to that. And we have also effectively become a supplier of last resort, where primary care or acute hospitals, social care, have not been able to get the response that they need in terms of supply chain. So we keep our own supply of PPE in order to be as responsive as we can. So we distribute PPE to primary care where necessary and other CCG services. We coordinate the mutual aid process, which Sonia mentioned. Effectively what we do is that we try as best we can to understand where the PPE is within our system, as well as our own stocks, and what deliveries are coming when in terms of stock and push stock in particular, and how much PPE providers currently have and how long that will last them. We then have a Devon Gold Command call on a daily basis, where we then go out to mutual aid to ask all organisations, also including hospices and community care, as I should have said as well, to see that we can attempt to resolve of any problems. We also have links in with the regional and national processes, and where necessary we've been able to escalate matters through those lines, which has been useful. So as I mentioned, we have those early processes for identifying what stock is where, and we monitor also the manifests in terms of stock delivery. I think it's probably well known, but very early on in the COVID crisis, it was clear that the normal NHS supply routes could not manage the PPE supply route, so separate processes have been set up both for large providers There is also the piloting of an e-commerce system within the peninsula, and within that we also work with other organisations in terms of the Local Resilience Fund, which I'll mention in a moment. There have been significant challenges. I think that's absolutely right to say, and we have tried our best to respond in sometimes very quick changing circumstances. So we've had early collaborative working with the councils, which has been incredibly helpful. Very often that might be, for example, advising on stock that is being purchased outside of the normal supply lines where there have been gaps in supply, and giving advice from a clinical point of view as to the suitability of PPE, particularly where it's been purchased outside of the UK. We have had a great response from Team Rubicon, who are all Army veterans who have come in and effectively helped us with our logistics. Most of the people within our PPE cell are clinicians and support staff within the CCG, so we've had to have that really emphasised. We've had to really re-emphasise the need that we need logistical help, and they've been absolutely marvellous, and effectively have quartermastered our own store, which is in the basement of County Hall, and also working with Devon 4x4 to make sure we can get targeted stocks forward as quickly as possible to the right place in the system. So moving on to ordering, as I've mentioned, the national supply chain, there is also a national line that we call the NDSL, which helps us to address some of those issues. Sometimes it hasn't been able to respond as quickly as we would like, so we have had to step in, and I'm very proud of the work that our teams have done around that. And as I say, there is an e-commerce solution, which is for small providers of health and social care who can't take pallet deliveries in the way that a large acute hospital necessarily could. I think I've dealt with most of those points, but we have had to be very creative, as you will have seen from other areas of the country. So hand sanitizers from local breweries, 3D printing visors, for example, from companies in Devon and our universities, as well as gathering stock from schools and universities of things like eye protection at various points. We're part of the Local Resilience Forum in terms of the PPE response to that. We actually get 10% of that ourselves, and we're very much involved with that. And Sonia and Joe and other colleagues are also involved with the work of the Local Resilience Forum, and that's been about working in a really collaborative way with other parts of the system. We've also developed a priority framework, so we're really clear when we're making decisions about who gets what PPE. We're basing that on not just the national guidance, but also where we consider the greatest clinical need to be. So far, I can say that from mutual aid, no one has been denied mutual aid. We've been able to send kit where it is required. And although we face those constant challenges that I've talked about, generally speaking, we are able to solve the problems that have occurred. We've also taken the initiative in terms of supporting care homes through our weekly webinars. Care homes there have been particular cases where it has been complex. We've attempted to respond as quickly as we can. Having said that, it's really just useful that the local authorities also have a key role in supply for care homes through the LRF, where those care homes can't achieve the PPE that they themselves need. So I'm going to pause there, and I know there have been some questions coming through on that. Paul.
So first of all, can I just say, or someone, can someone go on mute? So yeah, I'm hearing my voice back at me. Thank you. So first of all, can I say, Philip, that you've put on 6 slides there what is actually an immense amount of work and been an immense logistic challenge. I think we are no different to anywhere else in the country, and people will have seen by the number of statements and questions presented every day on the TV what a challenge PPE has been. And I think we have had to respond to national supplies. We've had to be very innovative in local solutions. And I think there is a thanks to local industry that has stepped in, and you've just touched on a couple of examples there, but there's been many examples of local industry that have stepped in to support us, and being flight of foot in how we respond. So I think there's so many elements here that have been pulled together to try and get us in a position where at the moment we have a supply that is sufficient for us around PPE. But I understand that that's almost a day by day situation that can fluctuate very quickly. So Philip, thank you for you and your team. Everyone is saying that it has been a helpful report. Judy, there's been some TV coverage that you just wanted to get a view on. Is that right?
Well, I mean, again, I agree with you. I think, Philip, you and your team are obviously doing a fabulous job. I've sat in on one of the care home seminars, and I think, we are going over and beyond our role in supporting them. I think you've been amazing. But I did notice on national television last night, a care home owner manager who was just very deeply frustrated about PPE and testing. He was talking about testing as well, which I know is not the subject of this report. And since this is a public meeting, I thought it might be just helpful. I appreciate you can't talk about individual cases, but I suppose just making sure we understand, perhaps there was something specific about that home, perhaps there was other stuff, or is that actually a very typical representation of how all our care home managers, leaders, senior staff are feeling, so that we could just set it in context, really. It's always difficult when something's on national television because it can give a national image of something going on in here. And if that was not a typical situation, then it would be good to understand. I hope my question makes sense.
It absolutely does. Thank you very much, Judy. I think it's a really important point. I haven't seen the specific news story, but I will, after this, go and look at that. And if there are specific issues, I will take those up. My assessment of the situation is that there are cases where there have been specific problems, and I think it would be wrong to say that everything has run entirely smoothly for every care home and every provider. I think we have, at last count I saw, 400 nursing and residential homes in Devon, and it's a very diverse and complex market. And I think that certainly I have dealt with specific cases where people haven't felt they've had the right response. And that's one of the reasons we set the webinar up, is that we wanted to give that coordinated view. Most of the time, and they aren't, certainly I would say that there are examples where people haven't felt that they are properly equipped to deal with both PPE and testing, and I think that's fair. We have responded in most cases to that. In fact, I would certainly say in all cases. But if there are specific cases where there is either anxiety around PPE or problems, then I'm very happy to step in. So I, for example, have given my own email address to care home providers where they feel they are just meeting systemic blocks or problems in the system, because frankly, I see that as part of all of our response to actually unblock that and make things happen. So I think it is, there are examples. I don't think it is commonplace and everywhere, to be fair, but I think where it happens, and I can entirely appreciate the massive frustration that this must cause to individual care homes and care home proprietors in particular. So I will follow those individual cases up, and that's my commitment in this public meeting.
Thank you.
Philip, thanks very much. Simon, you wanted to come in on this item as well.
Yeah, so this is so I think what Philip said, I endorse all of that, but I just wanted to give a bit of context as well to Judy. So I won't say which home this is or in which area, but I'm aware of a care home owner that's been charging in excess of £1,300 a week for a resident, well, in fact, all their residents. So not accepting what is a locally agreed price for residents and holding out for higher fees. Now that home had an infection outbreak, and it happened late one evening, or it was discovered late one evening. Had a good rating from CQC. When we did some work with them, the infection control procedures were not where they ought to be, and so obviously infection had spread throughout the home. The owner, who was the one that did the financial negotiations, could not be got hold of, so did not take responsibility at all for what was happening within his home. So I think we do need to recognise the fact that they are all independent businesses. That doesn't mean that we shouldn't support them appropriately, but there's a balance to be had in this. That's all. I just wanted to add that as context.
Yeah, thank you.
Thanks very much, Simon. Glynis has asked Philip a question around our level of stock, and do we plan to hold a larger stock of PPE locally into the future? I think Glynis might be quite optimistic here, but what's our plan around our stock levels?
So we have taken a short and medium term and longer term view of this. So in effect, we have been quite ahead of the game in terms of ordering stock that we can get, bearing in mind the lead-in time. So we have large amounts of stock that would come in to fulfill the needs that we have at the moment. I think the point Glynis makes is absolutely right in terms of where services will go in the next phase, and that's across the whole health and social care system. We will need to follow suit in terms of PPE. So I have a weekly call with our Director of Nursing colleagues across the system. We are talking about this on Friday because it's not just an issue for us, it is also an issue for our acute providers in terms of what will be needed going forward. So the short answer is where we need to, on the basis of predicted future demand, we absolutely will try and get, we will get ahead of that and take a proactive approach. I think my observation on that is that in the early days, we were having to respond very quickly, and it was a response rather than being proactive, because obviously this was a significant, fast-changing situation. I think we're now in the position of being able to get somewhat more on the front foot, and because we are now in our stride around the issues like PPE, and we have systems and rhythms and processes around that, it is a good time for us to absolutely revisit what we're going to need going forward.
Thank you very much, Philip. Thank you. And we will continue to be updated on our level of PPE. I'm going to move us on. I'm aware, Philip, that you will have to leave us. Yes. There's a system clinical reference group meeting in 15 minutes. And I'll ask you if you can make a start to that, and I'll join you when I can. But I'm just aware item 7 you're involved in presenting as well. So can I suggest that we take that item now, so Philip is present for that, and then we return to our individual elements of update relating to COVID. So Philip, that's for you and Sarah to take us through, and that starts on page 43.
So to help Philip, shall I let him go first?
That's really kind. I am just scrolling through. So if you've got any introductory comments, Sarah, okay. I'd be very grateful.
Of course. So this paper is twofold, really. It sets out the performance position to the end of last year, but importantly now makes clear the revised arrangements that are in place as a result of the pandemic from the 1st of April. Do you want me to continue, Philip? Or
yes, please. My machine is running slow. I do apologise.
So it's a detailed paper, and I don't expect to go. I'm sure I can pick up questions arising from the detail, but important to note that if we took one of our key performance indicators, such as the 4-hour waiting time in A&E, it's good to see that it ended up closer to the target at the end of last financial year. But obviously the reality of that is that it was as a consequence of the impact of the early stages of the pandemic and a reduction in patients coming forward. As we move forward, though, into the year from 1st of April, a variety of guidance has come out, which tells us now that we are asked as commissioners in large part to stand down our normal reporting arrangements, but to stay focused on constitutional standards. And they're very prescribed for us, and they require us to respect the fact that providers really should remain focused on pandemic support rather than in data collection. So the paper really advises members that in the period from April through to July, there'll be a very different performance reporting regime. I'll pause there because I think, Philip, you're now in the groove.
I am. Thank you very much, Sarah. So my element of this is probably best looked at from the slide pack that's in at page 63, 64 going onward. So just to say that I think it's really important to note that some of our governance processes, including quality, had been stepped down or deprioritised at the very beginning of the COVID pandemic. Included in that was the Quality Committee, and we were very clear that our focus should be around ensuring that there is any mitigation for risk that might occur within quality in terms of performance for the CCG, and that is what we have done. I have spoken with colleagues at our region, etc., to ensure that what we are doing around quality has been in line with the broader picture. And so there are certain functions that we absolutely felt it important to preserve. The first one of those relates to safeguarding, which has been incredibly important for us. So our safeguarding systems have not changed. And in fact, we have a greater degree of overview. Paul O'Sullivan, one of our commissioning colleagues, has been leading, for example, a system-wide discussion around children and COVID, and my safeguarding colleagues within my teams have been very much part of that. And the other elements relate to safety systems and patient experience, particularly around serious incidents and PALS, patient advice and liaison, and complaints. There is national guidance around that, which has suggested that response should be paused certainly on PALS and complaints. We have followed suit. In any event, we have seen a real slowing up in those. However, where there are issues that come through that route that are of specific concern, we continue to look at those actively, but they are by exception at this moment. And equally, serious incidents is something that we continue to look at. Now, I meet on a weekly basis to review the serious incidents and any issues that come out through PALS and complaints, or indeed any other safety systems issues by exception. And there is a report that then goes to Simon as accountable officer and other colleagues on a regular basis as to what that actually looks like. So if I can just move on and talk a little bit about some of the other work that I am doing around that, along with team, executive team and the quality team colleagues. So we have maintained and continue to improve our links with other parts of the system, particularly the Care Quality Commission. So I meet fortnightly, it has to be said, all of these meetings are virtual, to look at the whole system concerning any quality and safety issues that have occurred. That's not just in our health component, but I have also had a really good response from the adult social care element of the Care Quality Commission, and they indeed sit on our panel for our weekly care home webinars as well. So there's a very tight set of communication with not just the Care Quality Commission, but also with the local authorities, the QUATE teams, etc. I also have a weekly call, and indeed probably more frequent than weekly discussions with my Director of Nursing colleagues within Devon, and that's to facilitate specific discussion about elements of COVID and other services for non-COVID where there may be quality or other concerns. Chair and I also sit on weekly and sometimes 2 weekly calls with the medical directors and directors of nursing across our region as well, so to make sure that we are fully in step and in line with quality reporting and understanding of that. As we go forward, one of the requests that I've made to our regional colleagues is that in their framework for quality reporting, that they consider how the recovery phase is properly factored into that. I've had a conversation with Glynis Atherton this week, and following discussion at our executive meeting, we feel important that we step up our governance in line with any recovery of services, but that the Quality Assurance Committee should be the first of those to come back online. And so that is a discussion I have been having with Glynis around that, and we hope to progress that as soon as possible. People may have noticed that there is an ethical framework and indeed an ethical standards group, which the chair might want to mention because he sits on that group, and that is as part of our response with our clinical reference group across the whole system. That is the senior clinical leaders, i.e. the medical directors and nurse directors and other invited members across Devon, who meet on a weekly basis to consider any quality issues related to clinical services that need a further understanding and advice from that clinical reference group. It is not a decision-making group, but it enables us to ensure that we properly receive the assurance that we need on clinical services. So there is a short report there about some of the issues that we're currently dealing with. Those are my slides, and I am very happy to take any questions, albeit briefly, although maybe other colleagues may have to field some of those, given that unfortunately I will need to leave this call.
Thank you very much, Philip. Thank you, Sarah. And we'll certainly be picking up when we go back to item 5.6. Penny will be talking a little bit more about the ethical framework and that decision making process. So any questions or comments for either Philip or Sarah on the papers that we've just been through? Charlotte, did you want to talk? You wanted to mention about volunteers?
It was just a question that occurred to me when we're talking about safeguarding, and I just wondered, I don't know if we have any volunteers or whether that is all through the centralised volunteering and also with the existing voluntary sector who already have stuff in place. But I suppose it was just a question about safeguarding. Yes. And roles.
Yes, thank you, Charlotte. So yes, we do. There are appropriate checks in place in terms of individuals who come through as volunteers, and also we do have some returning nurses as well, people who've rejoined the register and wish to volunteer their services. So there are appropriate checks in place, as there would be for any new employee in terms of that. So I don't know, Andrew, if you want to say anything about that at all.
The only thing I would add to what you said, Philip, is I mean, Darren's doing a lot of work with the voluntary sector, certainly in terms of people who can help and support us. But I agree with you completely that on the check process, there's certainly adequate checks being taken to make sure that people are, are right.
Thank you both.
I'm going to have to leave, but
yeah, no, thank you very much, Philip. You go. Jo Turl is also going because she needs to be on the regional gold call. So thank you both for being part of the meeting. Sarah, the only thing I was going to say was actually thank you for bringing this report, because it's so easy for things like this to get lost in the urgency of what we're dealing with, and we need to be aware of how we were doing in regards to some of these core standards and performance going into COVID, and so it's really important that we make sure that we don't lose sight of that and pick it up as quickly as possible as we start bringing in some of that business as usual. So thank you for highlighting where we were towards the end of the last financial year. Thank you. Any other questions for Sarah? No. Well, then thank you very much. Thank you very much, Sarah. So let's go back to so Andrew, talking a little bit about our CCG workforce and staff testing, and then if you go straight through to 5.4 and talk us through around where we are with communications, both in-house and are you going to mention sort of MP and wider briefings as well in that?
Yes, I will, Chair.
Thanks very much.
Mindful of time, so I'll just mention a few things. So if I do the workforce and HR bits first, and before I cover those, I think as many people have said, I think it would be appropriate to thank all of our staff for their flexibility and professionalism throughout this period. I mean, we've seen many colleagues adapt to take on new roles, which has been great to see. So the HR team, as part of the HR cell, have been working with staff and line managers to identify who should continue with their work as normal, because we have got some people who are working, for example, in accounts, procurement, etc. Those who should move to work on coronavirus, in sales, and obviously in the incident management team, and then those, importantly, who could be redeployed to help providers. And I've got some update on some of the figures now, just to share with you on what we've done with our staff. So they've adapted really well. So we've got 280 staff temporarily working in different roles within the CCG to support the coronavirus challenge. Then we've got 120 who've started redeployment with external organisations. So those are mainly our providers in a range of roles using some of the skills our people have. And then, for example, in places like Devon Doctors. And then we're also looking at some of our staff who can help support the new NHS Nightingale Hospital in Exeter. We've got a small list of people, 12 at the moment, who are due to be redeployed externally, but there have been some delays with providers. So the executive team are going to go through those tomorrow, just to make sure we can place people in the best places to support our partner organisations. We've done a lot of work to support people's well-being, which I think is really important in this phase. So we're making sure that we as execs and also our line managers are checking in with their staff, particularly those who are out on redeployment, and also the checks that our non-exec colleagues have done with us has been fantastic. So I had a great call with Charlotte a few days ago, which was really appreciated. We're obviously doing regular team meetings via Teams, and we put together some bespoke guidance for managers to support people's mental health. We've also done a range of thank you calls for those who are out on redeployment. So Simon, I and others have done those personally. And we've also made our employee assistant programme available to employees. And that is also extended to colleagues working in general practice. There also is, as you probably know, some national health and wellbeing support for our staff as well, including a dedicated support line operated through Samaritans, and we've publicised those. And we've also signposted our staff to a range of other support, including financial support, carer organisations and the like. Piers and I are actively meeting now on a weekly basis with our staff partnership forum. It's a bit like a sort of trade union type forum, where we've got members of staff from across the organisation. And basically what we do is we have a two-way dialogue on a weekly basis, just to update them on what's going on, and also ask that they keep us abreast of anything that's happening with staff. So we just make sure we're covering any issues or staff welfare related problems. And they're actually now supporting with some of the new ideas that Simon's had to do some things with our staff to boost morale. So we're going to have a virtual reality, we're calling it, which is basically trying to get people connected on a matching basis, so they can have a cup of tea or a coffee and have a chat with people online, people that they probably normally wouldn't talk to. And I think that's important going forward. We're also involved in the Bringing Back Staff scheme, where we've had 209 former health professionals who volunteered to work in the NHS locally, and they're now being matched with various organisations. And we have about 50 who could work in primary care. So there's work at the moment being done by the HR cell to make sure that we place people in the best place. You mentioned, Chair, about testing, and as you know, the testing arrangements changed quite a bit. But we've had a few of our employees who've elected to be tested, but the numbers are really small. So 3 that we know of to date who've been tested. But of course, the new processes in place might mean that more of our colleagues will do so as that progresses. And the final thing I think I'll mention on the HR cell is just to give you a feel for our staff absence. So absence originally, when coronavirus started, was quite large across Devon, of the order of about 3,000 staff. That's fallen by about 1,000 now across Devon, so about 2,000 staff are absent. And in the CCG, the numbers are really, really low. So in the last briefing I gave, we had 25 people who were absent, but at the moment now we've got 12 who are either self-isolating but unable to work or absent for other reasons. So our staff are sort of are doing a great job really, but we haven't got problems with people being away. If I just cover the communications elements, Chair, that you asked. So with the communication cell, we're doing a lot of work both strategically to offer advice and help to different cells and operationally, so in terms of handling issues. And I'll just break it down by some of our core audiences. So for our staff, we now have an active video that goes to them, Simon presents, and a live webinar that's now going to be done on a fortnightly basis. And our first one last week was attended by about 350 of our colleagues. So actually what we've decided to do is moving forward, we'll try and stick with that. So we do have team briefings on a regular basis, but we'll try and do some live webinars as well because they were really positively received. As colleagues have said, we're also organising live webinars for 3 key audiences. So we have one for MPs once a week, which Jay, yourself and Simon host. We have a weekly webinar with GPs and practice staff. And as Philip mentioned, we've also got a new webinar for those working in care homes. And those have been really important for keeping key audiences up to date. We're also working really closely with the BBC particularly, and ITV and other media, just to make sure that we're clear on some of the advice to the public, and also obviously to update the media and the public about where we are in terms of handling coronavirus. We do have an active social media approach to promote messages to the public, and we now produce a daily bulletin which goes out across the Devon system, which is designed to assure them about how we're handling it, as well as to give them the latest guidance and advice as it comes in. So that goes out amongst primary care, secondary care and mental health colleagues. So it goes far and wide across the Devon system. And then the final thing I'll mention is the communication cell is also now supporting the new NHS Nightingale Hospital in Exeter. So I have a team of 3 people working with Philippa just to make sure as that progresses, we're really clear about messaging the right people, particularly staff who will be working in the hospital, and obviously residents and others who live alongside the new facility. So I'll pause there, Chair.
Thank you, Andrew. I think one of the things that's really positive for that is there's been an ask from our GP colleagues, from care homes, from the public for clarity, because there's been so much ambiguity, so much misinformation, particularly in the social media world, about what we're dealing with, that actually one of the things that they asked for, and I think the comms team have provided, and certainly the feedback we get, particularly through webinars, is the level of clarity that people have so that they're operating in a more certain world than they would be had we not been undertaking those. So thank you for doing those. Can I just ask on the staff element with the virtual teas? My ask is that we would expand that to make sure that invite goes out to our clinical, our GP sessional employees, and also to our non-executive governing board members, because I think it would be really helpful to give them an opportunity to link in and to get to know the rest of the staff as well, please. Okay. James has an offer that he does have a colleague who's providing some staff support over at DPT, and I'll ask you, James, to link in with Andrew to see whether there's any possibility of providing some extra support for some of the staff support that Andrew's doing. Any other questions or comments for Andrew? Simon.
Yeah, so Andrew, one of the things we've just so it's very early days, isn't it? But we were looking at is, so we do a lot of social media, a lot of contact with the public through digital means, but we've just started to explore early days with whether we can actually do something in print, haven't we? So there's been a launch of a paper in the Torbay area that's a jointly between the hospital trust, the police and the local authority, and that mechanism may be able to be replicated across the county, where we can reach people that haven't got digital solutions for our comms. So we can come back at a later stage about that, haven't we? But that's something we're exploring, isn't it?
That is really positive, Simon. Yeah, I think gives us a great opportunity to get messages directly, doesn't it? In a way which really will be helpful for certain audiences. Absolutely.
Okay. Anything else for Andrew? No. Well, then, thank you very much. Thank you, Andrew, for that. It'll be good to get to hear some individual stories of how those virtual teas go. James, I think the more often we remind ourselves of that, the better. You're saying that when we're engaging with the public, let's be mindful of acronym usage. We can very easily slip into language that we are very familiar with, but will be completely foreign to our public. So that's a useful reminder for us to keep at the forefront of our minds. Thank you, James. So Sarah and Penny for item 5.5, update on discharge.
Thank you, Chair. I'm going to speak to this, but Penny and I are both joint executive leads for this bit of work, so I'm sure Penny and I will handle questions at the end. The guidance on discharge came out in March, and Simon asked us at that point to establish the cell as part of the incident response. The cell is actually called 7-day discharge planning and access to out of hospital care. Not terribly short and snappy, but it is what it says. And that national guidance was supplemented yesterday in the letter from Simon Stevens, because he emphasises the importance of sustaining hospital discharge service and preparing to support the increase in patients who've recovered from COVID-19. It also emphasises how important community services are and out of hospital care. So we are mandated to continue this work certainly in the foreseeable future. The way the group operates, or the cell operates, is that over 7 days of the week we are responsible for working with our providers, and that's all providers, including acute, community and integrated care providers, to maintain minimal bed occupancy levels to prepare and support during a period of surge. Now, thus far, we've been doing that against the national guidance at 50%, but we moved that yesterday to 65% in direct response to the changing circumstances we're seeing locally of increased volume of patients now coming into our hospitals. The second main purpose of the cell is to support and coordinate and communicate across out-of-hospital care, and to make sure we use all available capacity, with particular reference to end-of-life services and working with care homes that we touched on earlier. And when we are shaping our response to capacity, to out of hospital capacity, we're now thinking of opportunities for more innovative ways of working, different solutions, and that's going to be very important going forward, particularly if we have to respond to a further surge. So in practical terms, Penny or I chair a daily meeting with locality teams who are led by an associate director and well supported, and we systematically go through individual patient requirements by provider to make sure we're completely making sure that we've got no blockages that we can't resolve as a system. We've had now included within the cell the continuing healthcare team and the market management team as well, so that they're able to take and handle complex discharges where they've got already very well established relationships that we can build on. This is early days for this kind of work, so we completely accept that there's learning experience to be captured, and we've got a coming together session next week so we can review and reflect on what we've learned, particularly because by that stage we will have covered 2 weekends as well, and we need to understand what the discharge arrangements are over weekends. I'm going to pause there. Penny, is there anything else that you'd like to add?
No, I don't think so. Thank you, Sarah. I think that's a really good, thorough picture of what we're doing. I think it's the commitment of everyone to work together with all their partners, which is making the difference. So not only are we going through every case that's getting stuck, but we're also going through it with the providers, with the local authority, with our own teams. And it's that working together that's absolutely critical.
So thank you very much, both. I'm waiting to see. We've not got any questions or comments coming up. Can I just ask, because one of the things that we are so dependent on our local authority colleagues for effective discharges, that the sort of the link in with our 3 local authorities around social care and around care home placement, how is that working?
If I go first, I'm sure Penny will want to add to it. Within our arrangements, we've got the opportunity of working with colleagues who are joint appointments between local authorities and the CCG. And I think this really works well for us in the sense that we're maximising on the opportunity of working ever more closely.
Thank you.
Nothing to add.
Okay, and there's a positive comment from Simon Kerr saying that systemisation of discharge across Devon will be helpful. Looking forward to hearing more. Okay, so obviously there is the support that this that feels like the right thing to do. Okay, thank you very much. Then Penny, it's still you. It's because we're on to item 5.6, which is the ethical framework and ethical decision making.
Thank you, Paul. This is a topic that I could talk about for ages, so I won't. But essentially, it's really, really important for the board that we are really clear that the decision-making processes during a pandemic are consistent, and particularly consistent across our system, so that we have an assurance of both of fairness, both between COVID and non-COVID, but also across organisations. So the ethical framework has been something we've been developing for a little while within the CCG, but recently we've set up a Devon-wide ethical reference group, which is chaired by Dame Susie Leather. Now, Paul and Glynis are both members of that, so I'm not going to talk in great detail. I'm sure they can, but I thought it would be helpful if I just give a little bit of context to that. Because although there's a Southwest Regional Ethics Reference Group for Health and Social Care, and all providers typically have a committee, an ethics committee providing assurance to their boards, at this time it's really, really important when you're moving into a pandemic situation. If we were to get into surge, and we talked earlier that we're not, when choices start to be made, that we do so in a consistent fashion, and that's what this is all about. There is a piece of work being done from the regional point of view from clinical leaders, which particularly Sarah and I have been linked into through the critical care cell, which is advice for clinicians regarding the Southwest systematic approach to treatment and referral decisions during COVID-19 pandemic. It's a snappy title, as you can tell. It's a framework, but like anything else that's around at the moment, there are some gaps in it, and that's what the piece of work that we're looking at. We are particularly through developing a Devon-wide ethical framework, and that's got key elements of a consistent set of principles, a very clear infrastructure which shows how we link from the providers to the system-wide arrangements to region, and also a set of decision-making tools that we're developing, which is actually the gap in the others' work. And that's the bit that the clinicians are looking for when you're on the front line and having to make difficult decisions. I have to say, and I'll stress it again, you're not in surge at the minute, and this is about precautionary planning, but it's really important we do this work now. And we have based the work that we're developing on the Department of Health and Social Care ethical principles for pandemic flu. So it's a path that other people have tread before. From the CCG point of view, we've asked the Devon-wide ethical reference group to actually act as our ethics committee as well. And that I know they're minded to agree, but also we need to look at very clearly what it is, the sort of things we might be putting their way before they finally sign up to that responsibility. But as an independent group, they're really important to us, and it's a really fantastic group that Susie has managed to get together. I have the list of the attendees here, and I'm happy to circulate it after this meeting. But some very prominent professors, both from Professor of Divinity, from former Bishop of Oxford, through to university hospitals representatives, through to Professor of Medical Law and Ethics at the London School of Economics. It's a very, very strong committee, and I'm sure Paul and Glynis might want to comment when I finish. The work we're doing, we're not at the stage to share it yet. There's some final pieces of work we need to do, and obviously it needs to be adopted across the system. It is very much a framework and very much a tool to help in the decision making, to help us make sure that we take maximum advantage of the resources we've got to benefit the maximum number of people. And the principles in the framework as it's developing are very much around equal concern and respect for everybody in our population. So without going into those details today, because I think it's very difficult when people haven't seen the draft and recognising where it is, we are taking legal advice on it. We will be doing public engagement on it, and it will be something we're looking to adopt across the whole system so we get that consistent approach. So the next steps for us is to be clear that Devon Ethical Group are happy to cover the CCG business as well as the system-wide, to finalise that framework and to finalise our draft decision-making tools, as I said, with both legal input, and we will be putting it out to the public in due course for feedback, recognising that in the situation we are in, that will be time limited, but it will be for everybody to have an opportunity to comment. So I just want to repeat, this is precautionary planning work. We're not expecting to reach the scenario currently where we'll have to use it, but we need to have it there in case in the future it might be needed. It is all based on the principles of equal concern and respect for everyone, and everyone matters. And I think it's a very, very detailed piece of work, and I'm delighted that the committee's come together and we're able to work with them on this.
Thank you very much, Penny. That was a really good summary of where we've got to and what the next steps are. Glynis, is there anything that you wanted to add, particularly around the System Ethical Reference Group?
No, I think Penny has summarised it beautifully. Thank you very much.
Okay. And I think just what might be helpful just to clarify is that there was a national ask for regions to set up something around an ethical reference body, for systems to have one, and also for all provider organisations to have an ethical committee, and they are establishing those. And we took the view that what we needed was expert advice for our own committees to make the decisions that they're already set up to make, and hence our approach that we couldn't get a better expert panel than the one that Susie has got together, and hence the ask that they would be providing that advice that we could then use to inform our own internal decision making. Any comments or questions around that? Then all appears quiet. And Penny, the ethical framework will come to our governing body for organisational approval once it's been through these next few steps. Is that right?
That's correct. It will go to all of the boards along with a decision-making tool. Okay. But we, as I said to you, we have taken legal advice, and that legal advice is very clear. We'll also have to put it out to public engagement because it's really important. But as I just think the principles are, for me, really, really significant. It is about equal concern and respect.
Yeah. Okay. Thank you very much. Thank you, Penny. John Dowell, let's move to item 6, which is our last item because we've already covered item 7. Last item on our agenda for today's governing body. Over to you.
Okay, thanks, Paul. I'll be brief, just updating on 3 things today. So it was back at the around the middle of March when the Chancellor stood up and said that that money should not be a barrier to the COVID response, and the NHS would receive the resources that it needs. And we've tried to sort of follow that through at a local level. We were also reminded that we need to ensure during the period we maintain good governance and some semblance of control, and hence the things I'm reporting to you today. The first of those is probably one of the closest things to anything like normal that we've had at the moment is we are required to produce annual accounts as in any year for the close down of 2019-20, and so a team of people have been working on that, and our accounts, I'm pleased to report, were submitted on time to NHS England and to our auditors earlier this week. And our auditors, Grant Thornton, will now be working on those, and those will come back as audited accounts for adoption by governing body in due course. Those accounts confirmed the year-end position that we've been reporting for some time, which was a £66.5 million deficit, which is about £39.5 million off plan. But as I say, that is where we've been reporting for some time. The second thing that we've been working on, which I'm reporting to, are the collection of additional costs in relation to the COVID response. We've got systems and processes in place for doing that. For the year just ended 2019-20, and included in those accounts that I've mentioned, we recorded a total of 564,000 of additional revenue costs incurred directly by the CCG, and 757,000 of additional capital equipment costs incurred directly by the CCG. Our systems and processes are in place and will continue for the duration of the emergency response period, and those will be reported to governing body again as part of regular updates on a monthly basis. The other thing we're doing in that space is to ensure that we do continue prompt payment to suppliers. So suppliers of all kinds, whether that be health and care sector or suppliers of goods and services, we are working as hard as we can with colleagues to ensure that people get paid promptly to help with the sort of financial impact that's created from elsewhere in the economy by the shutdown and so on. And the last thing to update then is the arrangements that we've put in place for financial planning and budgetary control for 2021, because of the timing of when we entered the emergency response period. It was right at the beginning of the financial year, and our 2021 operational plan had not been signed off at that point by NHS England. We are setting budgets nonetheless on that basis. So we're setting budgets and issuing budgets to budget holders based on our expectations of the operational plan. We're then recording any additional costs related to the COVID response as explainable variances from that plan. And we've talked a number of times today about starting to think about how we exit from the emergency response into something that won't look like business as usual, in the sense of it won't be exactly the same as it was before, but it will become something that is more usual for the next period, and how we reset our budget will be a part of that, because what we will have learned is a number of things around what the demand for services looks like and what the drivers of cost are very different from how they were when we entered the emergency response period. And I do think it's worthwhile reminding ourselves at that point that a number of the things that we set out to do in the long-term plan and that were described in our operational plan on which our budgets were set, we wouldn't have anticipated what the catalyst was, but in fact a number of those things are what we are now doing. So a lot of the things in the long-term plan around increasing the use of digital and the way in which we provide services to people, we have moved very quickly into that territory, and that will have had a big impact on the way that we spend our money. So a big part of the next phase, certainly for myself and my colleagues in provider sector, is to think about what that looks like for the rest of this financial year as we start to emerge from the emergency period. And again, we'll update governing body further on that at the next meeting.
Thank you very much, John. And Judy has a comment. Really, is just a congratulatory comment for you and the staff, given everything that's going on, for keeping the financial systems going smoothly within all this change. So I would echo that, and so have Simon and Charlotte. So yeah, I think take that as written, really. So thank you very much for you, and if you can pass that on to your team, Graham.
Well, thanks. Yeah.
Thank you, Chair. Let me also just add my thanks to John and his colleagues for getting the accounts in on time and for there being no surprises. The deficit is obviously disappointing, but it's the figure we've known for several months. So thanks very much, John. I just wanted to make one comment on the report. John covered 3 issues, and all of those are covered in the recommendations when we're asked to note the recommendations. I think in the case of the latter one, regarding the interim budgetary control, I would probably want to see the governing body formally approve that action, given that the last Finance Committee was at the start of the COVID process and we had to cancel the meeting. I think for belt and braces purposes, I'd like to see us just formally as a governing body approve the action that John has taken, quite rightly, with the budgetary process.
So I'm very happy to make that adjustment. So there are 2 elements to note, which are the first 2, and then the to approve the interim position that John is suggesting. So I'll take the first 2 as given, as there is no comment coming up against that. And then I'll just pause to see if there's any more questions before we look at then formally approving the latter point. Okay, so in the absence of any other questions, I will ask a governing body. We've not had to do an approval electronically, so I'm going to have to ask people. I'm going to assume that people are in favour of this, unless I see anything else in the chat element that says otherwise. So that we approve John's approach to the interim budgetary control approach. And I've had at least 2 yeses and no nos. So I think that's that. I'll take that as approval. Thank you very much, John. Thank you. And the yeses are coming in now. This is like a delayed vote on Eurovision. So John, your song has won. So thank you very much. So thank you very much for that. Okay, I think one question amongst the yeses came through. Simon Kerr, do you think we are heading into a new way of funding CHC? So I suppose that's a question to speculate on, John, as much as you are able to at the moment.
Yeah, so I'll resist the temptation to speculate, I think, but I mean, what's clear, a number of the interim arrangements, I think, will be considered quite carefully at a national level. I think we as a group of finance directors are talking from time to time with Julian Kelly, who's the national finance director, about learning the lessons, as we've talked a number of times during this meeting, about learning the lessons from what's worked well and has helped during the COVID response and what might need to stay in place. Now, I'm not sure that that all of the arrangements around CHC will fall into that category, but I think there is careful consideration at a national level about what of the interim changes might be sensible things to leave in place.
Thank you very much, John. And then on that note, I'm going to formally close the governing body meeting. I'm going to say thank you all for your contributions, and thank you particularly to the executives who prepared papers or prepared verbal reports for us. And there is definitely we are more informed and more assured of the CCG's function and position during this time. And we will have our next public governing body meeting in May as already planned. So thank you all. Take care and stay safe.
Thank you very much.
Bye all.
Goodbye all. Thank you.
Thank you. Bye.
Bye.
Bye. Thank you very much.
Right, bye everybody.